Good morning, everyone, and welcome. This is another episode of our monthly webcast. It's all in your head. And the topic for today is depression. Somebody once said that depression is when you wake up screaming and you realize you haven't fallen asleep yet. Now, depression and coping with it is certainly not a joke, but perhaps a little bit of laughter can also be helpful. To spread the joy, here's one story. A woman went to the doctor's office with her husband. After his checkup, the doctor called the wife into his office alone. He said, "Your husband is suffering from very severe depression. If you don't do the following, your husband will surely die." The doctor continued, "Each morning, take him a healthy breakfast. Be pleasant at all times. For lunch, make him a nutritious meal. For dinner, prepare a especially nice meal for him. Don't burden him with chores. Don't discuss your problems with him. It will only make his depression worse. No nagging. And most importantly, make love with your husband several times a week. If you can do this for the next 10 months to a year, I think your husband will regain his health completely." On the way home, the husband asked his wife, "What did the doctor say?" To which his wife responded, "He said you are going to die." Now, on the serious note, I have Dr. Swingle here today to tell us about the remarkable efficiency of neurotherapeutic treatments for depression. But first, let me give you a brief summary of Dr. Swingle's background. Dr. Swingle was titular full professor of psychology at the University of Ottawa prior to moving to Vancouver. Fellow of the Canadian Psychological Association, Dr. Swingle was lecturer in psychiatry at Harvard Medical School, attending psychologist at McLean Hospital in Boston, where he also was coordinator of the clinical psychophysiology service. Dr. Swingle is a psychologist in British Columbia, certified in biofeedback and neurotherapy. His newest book, Biofeedback for the Brain, was published by Rutgers University Press. The book is available online at www.soundhealthproducts.com. We will have 2 breaks during this webcast to answer your questions. If you get any questions or comments, send them my way by using the chat feature on control panel on the right side of your screen. And now, without further ado, here is Dr. Swingle. Good morning.
Good morning. So, as Rita said, the topic for today is depression. And at this time of year, some people are particularly vulnerable to have more to say about that. A lot of people respond to changes in light and changes in the circadian rhythm and so forth. Now, in terms of the factors in depression, we'll be going over these today. Of course, genetics, big component to individuals who have a predisposition to depressed mood state. And we'll be going over some of the neurology of this, so we'll be able to look at some of the differences between what the neurology looks like for a genetic disposed condition in which an individual has a genetic predisposition for depression versus the experiential conditions that give rise to depressed mood state. And there are huge differences in the way we should be treating a genetic predisposition, or what we used to call endogenous depression, versus one that's a function of your experience, exogenous or reactive depression. Trauma is a big issue. Individuals that experience trauma and whether they are genetically prepared to deal with some of the stressors associated with that. Anxiety, of course, is a huge component to depression. And we will be going over cases in which the wrong condition is being treated. A lot of individuals who have a severe anxiety condition define that as depression, and it's treated poorly, usually in terms of treating it as depression. And we also have disease states, of course. Now, depression. I love this cartoon. uh, Depression is characterized primarily by an imbalance in the front part of the brain, the frontal preorbital cortex areas. And the fundamental issue associated with depression is when the right side of the brain is more active than the left. And there are a lot of ways this can happen. This is the primary condition that we see that is a genetically based predisposition to depression. This is raw data that you're looking at here. And those two numbers, 26.5 and 16.7, the 26.5 is the amplitude, the strength of beta, 16 to 25 cycles a second, at location F4, which is the right frontal cortex. 16.7 is the strength or amplitude of that same waveform, beta, 16 to 25 cycles a second, in the left, that is F3, which we'll see in a minute, the left prefrontal cortex. The disparity here is 57%. This is a huge marker for predisposition to depressed mood states. And here's the summary. And goes to the numbers we were just looking at. And F4 is considerably greater than F3, 58.6%. And the locations that we're talking about, here's the right prefrontal cortex, there's the left prefrontal cortex, and when the right is more active than the left, that's your marker for depression. And as I said, there are a lot of ways this can happen, and there are huge qualitative differences between the conditions under which the right becomes more active than the left, and we'll be going over those in some detail. Now, this is a topographic representation of brainwave activity of an individual who has both anxiety and depression. Now, the anxiety is in the back of the brain. There are several markers for anxiety, but this one is poor stress tolerance and sleep disturbance, and that's when beta, 16 to 25, or in this case 15 to 30, is considerably elevated in the back part of the brain. And the metaphor we use is the person cannot find the switch to turn the brain off. Poor stress tolerance, anxiety, poor sleep quality, can't shut the brain down, predisposition to addictive behavior, and fatigue. Now, remember, the cardinal marker for depression is when the right is more active than the left. Now, this is another way in which the right side of the brain can be more active than the left. And that is because the left side has elevated slow frequency. This is theta, 3 to 7 cycles a second. And theta is very, very elevated in the left, meaning that the left is hypoactive relative to the right. So this is the second method that you can have the right side of the brain being more active than the left. Now, there's a qualitative difference that we often find between this condition in which the left is subdued, or rendered hypoactive because of elevated theta, or the right more active because of elevated beta. The elevated beta in the right tends to be a genetic condition, at least clinically, that's what we feel. Whereas when there's elevated theta on this side, it may be experiential. So, for example, an individual who feels they can't cope, their life is crashing in around them, may develop this, but the cause of it may be the anxiety. And there are very important differences in the way this should be treated, both in terms of pharmaceuticals, therapies, and of course neurotherapy in particular. So we go after the areas that are associated with the disorder. And that's the real power of neurotherapy. And that is, we know precisely where in the brain we go to fix this problem. So there's no hit and miss, try this, try that kind of business. And we can break it down quite subtly in terms of single brainwave bins. So here's 21 cycles a second, 22, 23, and so forth. Now here we have the elevated beta fast frequency sitting right up over in the right. There's your marker for depression. And we also have elevated fast frequency in the back of the brain. Okay. Now the beauty of this, breaking it down 1 hertz bins, is you'll notice there's no problem in terms of the elevated fast frequency up in the 26 to 30 range. It's all sitting down here, 21 to 25. So we can be very, very precise in terms of how we treat this condition. And treating it, the complaint, of course, is anxiety, sleep problem, and depression. And you can see it all sitting right there. We, of course, get multiple depression markers in which an individual may have a predisposition, a genetic predisposition to depression, and may have some experiential factors that are contributing to it. And here's a good example of that. Here's the old beta, much greater in the right relative to the left. So it's 22.5 in the right, 11.8 in the left. The difference there is 134%. That is, the right is 134% stronger than the left. And here's your experiential marker in which the left side of the brain has elevated theta amplitude relative to the right. And it can be a combination of these two, which is the theta-beta ratio, in which the ratio of the theta relative to the beta is, as you can see, considerably greater in the left, meaning the left side of the brain is much less active than the right. And here's the summary of this. Here's the deficient theta-beta ratio in the back of the brain, so we have anxiety. Here's the elevated beta amplitude. So beta is considerably greater in the right relative to the left. Anxiety marker. And in this case, we have elevated theta sitting over in the right relative to the left, and that's a mark for emotional volatility. And the diagnosis that these people often come in with is bipolar. Bipolar, anxiety, emotional volatility, depression. So in that, what we're looking at again is the right side of the brain being more active than the left, and there are lots of ways this can happen, and coupled with deficiency in the occipital region in the brain, meaning the person can't find the switch to turn the brain off. The brain is not efficient at stress tolerance. It also usually implicates sleep, and if sleep is disrupted, everything is worse. Now, pediatric depression. And this is often difficult to see because often the child will not present apparently sad. They will present a just lack of interest in things, or they will seem to be hyper. Now, one of the things that we find often in a child that looks as though they're depressed is that they're experiencing some severe stressor, emotional stressor. And we can usually pick this up when we do the brain assessments on these kids. And this is an example of that, in which we have a situation in which we're suspicious that this child is experiencing some severe emotional stressor. Now, we have to consider the possibility that the stressors in the home, an abusive parent, or a situation in which parents are in severe conflict and ready to separate and divorce and all that sort of business. And we run into this routinely with these children that are brought in for depression or ADD or whatever. So we always have a look at this. Now, here's a case in which we're suspicious of bullying. First of all, right on top of the head at location CZ, what we're seeing here is blunting of the alpha response. Alpha brainwaves from 8 to 12 cycles a second. And when you close your eyes, there should be a nice increase in the strength of alpha. And the reason for that is you're shutting off the visual system. So alpha increases markedly. And you should see it in both the front and the back. Now, when we see it only in the front part of the brain, that is up over the top of the head, then we're suspicious that this trauma, if you want to use that term, or this severe emotional stress is current. The second thing that we're seeing here is that this child does have a mild marker for ADD. And there are many, many forms of ADD, and listeners that are interested in that can access the Swingle Clinic website and download one of the webinars on ADD and learning disorders. But for our purposes, this particular form of ADD, we want to see these numbers below about 2.2 or so. So you can see there's a mild elevation in excessive amount of slow frequency up on top of the head. So I know this child has a bit of a problem in terms of focus and attention. But the red flag here is that trauma marker. Now, back of the brain. O1 is the back of the brain, and we were just looking at that in terms of anxiety. And here we have a marker for, this is relatively low for a child 9 years of age. So my guess is that he has a sleep problem and he's anxious. Okay, front part of the brain. Here the flags really go up. Here we have a situation, and this is the third pattern that's associated with depression, and that's when alpha is stronger in the left relative to the right, meaning that the left is hypoactive relative to the right, meaning again that the right is more active than the left. This is the one that was discovered about 15 years or so ago by Richard Davidson, in which if you make people unhappy in some way experimentally, you can pick up an increase in alpha on the left side of the brain, reflective of their being sad. So here we have what we think is a reactive depression. That is, the child is depressed because of something that's happening to him. And remember, we've got a trauma marker. So we have two indicators here. One is reactive depression. The first is that there's some incidence of his being exposed to a severe emotional stressor. Now, the real feature here is that theta is markedly elevated in the right side of the brain relative to the left, and that's a marker for emotional volatility. Now, remember, we saw that just a few minutes ago when we were talking about bipolar, emotional volatility. Now, in a very young child, this characteristic makes them a sitting duck for bullies. They react. This is the young boy who will cry at almost anything and get highly upset. And bullies just love to taunt these kids. So here we've got it. And we've got a reactive depression. We have a child who's vulnerable to bullying. We have a trauma marker, and we have poor stress tolerance. Okay? So my suspicion is that the problem with this child, in terms of his sadness and his inability to function and his not wanting to go to school and so forth, is he's confronted with a bully, and he's afraid. And it turned out that was exactly what was happening with this child. And what we had here is we had elevated theta sitting over here, which was the hyperreactivity factor, which made him a sitting duck for bullies. He had elevated alpha activity sitting over on the left, which is a reactive depression. He had blunted alpha up here, which is a marker for exposure to severe emotional stress, and he had poor stress tolerance. Antidepressants, the data on antidepressants is not good, as you probably know. That individuals that are on long-term antidepressants have more incidence of depression than those who don't, and so forth. I suspect that most of the listeners have looked at some of these data in terms of the very discouraging hit rate for antidepressants and huge problems associated with side effects. Now, part of the problem here is that often the nature of the medication that's given is inappropriate, that the data on the antidepressant would be far more encouraging if they gave the medication for the right reason. And they're using neurotherapy now, quantitative EEGs, to determine potential reactivity to specific medications, making the medication process much more efficacious. This came from the American Medical Association, and they found that the difference between placebo and antidepressants is only about 5%.
Thank you, Dr. Singh. And this is our Q&A time, and I have a first question here. Family member committed suicide a number of years ago. There were no warning signs that any of us noticed. He had some depression prior, but seemed to be doing well. Are there ways to determine suicide risk, even if the person is okay?
Yeah, I'm sorry to hear that. This is a real problem that therapists who deal with these kind of severe conditions are facing all the time. And that is, how do you assess suicidality? In adolescence, there's this notion that they joke around a lot about it. I always take it very seriously. The other thing is what's implied in this question, I believe, is that the individual appeared to be okay. And clinically, we have an issue or a condition that we refer to as the coming up problem. And that is when an individual is in treatment and they start to feel better, they go through a period of increased suicide risk. Now, there are a lot of notions about what that's all about, and some people feel that it's an empowerment issue, and that is one of the features associated with depression is that it deprives you of interest and motivation and energy, so that, I know this sounds foolish, but the person just doesn't have enough energy to commit suicide. And when they start to feel better, their energy returns and they feel empowered, so to speak, and the world just looks grim. They're going through an existential crisis, like, what's the point of all of this nonsense? I might as well just kill myself. They put up risk, the FDA has put up risk markers in terms of side effects of some antidepressant medication. But I don't think they followed through on that. I think really what the psychopharmacologists are facing is exactly the same thing we face in the neurological approaches to this. And that is when they give them an antidepressant that's efficacious and this person starts to feel better, they go through that coming up risk period. So the answer to your question is vigilance, and sometimes you don't see anything, and when a person feels better, that may actually signal not lower risk, but higher risk of suicidality.
Apart from Omni, is there anything we could use to increase and or decrease theta waves in brain driving?
Yeah, Omni is the one, for the listeners who don't know what Omni is, Omni is a harmonic sound that we use for children that have ADD, for example, in which we want to decrease the strength, amplitude of theta activity in the brain. We also use it for epileptics because elevated slow frequency lowers the seizure threshold. Now, there are other ways of decreasing theta amplitude. For example, acupuncture, if you stimulate the spleen meridian, that tends to reduce theta amplitude. We also use flashing lights, and if you use flashing lights in the very low ranges, what we use in one of my brain driving protocols is 3 hertz and 7.8 hertz. And it has it can be very effective for, I'm sorry, I'm thinking of something else. We use frequencies in the 11 to 16 range to decrease theta amplitude.
Okay, and next question. Should even a 9-year-old have theta-beta ratio below 2.2?
Oh, yes, sure. And now, if we have a ratio sitting up around 2.4 or so for a child that's 6 or 7 years of age, that usually is not unusual because the younger you are, the more theta you have. But it depends on what they've been brought in for. Usually you start to see the ADD issue much later in the child, 8, 9 years of age before they actually show up on our doorstep. What you're likely to see at the young age is severe hyperactivity. And there you get theta-beta ratio sitting up in the 4 and 5 range. That's a different ball game altogether.
Thank you, Dr. Singh. So we are going to take one last question now, and we'll be answering the rest during our second Q&A time. So the question is, my mother has been on various antidepressants for
Yeah, Rita, I think your mic kicked out. I wasn't hearing it here, so let me just...
Oh, I'm sorry. Okay, I'm going to maybe read the question one more time. I think I forgot to unmute my microphone. I just mentioned that we are going to take one last question, and the rest of the questions we are going to answer during the second Q&A time. And the question was, my mother has been on various antidepressants for many years and seems as bad off and depressed as she ever was. Her doctors change the medications occasionally, but she still seems miserable. Are there some patients who just don't respond to antidepressant medicines?
Yes, there are people who don't respond well to the medications for all sorts of reasons, but the general feature that we find of clients who show up on our doorstep who are very heavily medicated but in very bad shape is they're medicating the wrong problem. And this is where the brain assessments, the clinical QEEG, that is the electroencephalograph, is so powerful because it tells you exactly what it is that you're dealing with and where to go to fix it. And that can be with medication as well. I mean, neurotherapy is not the only game in town by any means. And when I was at Harvard Medical School working with some of the best psychopharmacologists on the planet, they did miracles, but they knew what they were doing with regard to this, and they were following the neurology of it. If you have a person that's been medicated for 20 years and they're still in bad shape, you're medicating the wrong stuff. Or the implication of your question is there are people who have characteristics that make them unresponsive or less responsive or poorly responsive to pharmaceuticals.
Thank you, and let's move on.
Okay, anxiety. This is the number one characteristic associated with medication problems. That is when an individual has an anxiety condition that's being defined as depression, and they're given antidepressant medication. It just doesn't work well. Here is anxiety-based, quote, end quote, depression. First of all, the first thing that we're seeing here is we're seeing that there's a marker here for exposure to emotional stress. However, the critical element here is in the back of the brain. We're seeing that the theta-beta ratios here are very, very low. We want this up around 1.8 or so, and eyes open is 0.66, eyes closed 0.49. Now, look at the data here. Here's a 50-year-old man, long depression history, most of his life, long medication and psychotherapy history, and the medications that he's been given are mostly antidepressants. And here's the front part of the brain. There's no marker for depression. Zero. So the problem here is this person has a severe anxiety condition and emotional volatility. Remember, if there is elevated theta in the right relative to the left, that's your marker for emotional volatility. Now, here's another area of the brain we haven't discussed yet. And this is the anterior cingulate gyrus. That is, it's a subcortical structure just below the front medial part of the brain. And what we're looking at here is a marker for severe worry and an OCD-like behavior pattern. Get something on your mind, you can't get it out. The value here, this is a summation of all of the beta amplitudes. We want this below about 15. So he's about 3 times what the break point is for excessive fretting. So we have a severe anxiety case here. The medications, the reason we're going through this whole problem here is that it's being defined as depression. Now, of course, the guy's depressed. His life is falling apart. He's out of control. He doesn't know what to do. He's horribly sleep deprived and fatigued, and of course he's depressed. But that doesn't mean that antidepressant medication is going to do anything for him, because what you have to go after here are the number of markers associated with anxiety. And there are medications that will attack this and deal with it, and neurotherapy, of course, would be my primary choice here, because we can go directly to these locations, which in fact is exactly what we did, and take care of the anxiety and then titrate down off all of the medications. Here's another situation. And if the left side of the brain is considerably more active than the right, that's your genetic marker, or the second genetic marker for anxiety. And here it is right here, where the beta amplitude, that is the strength of 16 to 25 cycle a second activity, is considerably greater in the left, F3, than the right, 36% so. And this is what sleep problem looks like when you're doing an assessment on somebody. Now remember, we were talking about the back of the brain. When the theta-beta ratio, that is when the ratio of the strength of beta is considerably greater than the strength of theta, that means poor stress tolerance and usually a sleep quality problem. And this is what it looks like when you're testing the person. What we have here are 10 trials of 15 seconds each. And here I have the person keep their eyes open. So eyes open, eyes open, eyes open. And then I ask the person to close her eyes. This is what it should not look like. When you close your eyes, the brain here is turning on. Beta is almost 3 times what it is eyes closed condition. There's your hallmark marker for a sleep disturbance. Marked elevation in beta amplitude. I can bet the farm that this person's going to report and admit to a serious sleep problem, which in fact she did. So, the summary of depression, any condition that gives rise to the right side being more active than the left. And these are the ones we just discussed, where alpha is considerably greater in the left relative to the right, meaning the left is hypoactive relative to the right. Hence, the right's more active than the left. The genetic expression of this, or at least what we think is the genetic expression, is when F4 beta is considerably greater than F3. That is, then the right has more beta than the left, meaning the right is more active than the left. Theta, when theta is greater on the left relative to the right, means the right's more active than the left. And a combination of these, if you have marginal excess theta in the left and marginal excess beta in the right, it means that the combination of these two is going to make the right side of the brain more active than the left. Cardinal feature associated with anxiety-based depression. Now, it's not really depression now, it's anxiety, but often defined as depression, is when the slow-fast ratio in the back of the brain is considerably under 1.8. Anxiety, the one that we just mentioned, and in addition, the frontal. So any condition that leads to the right side of the brain being considerably less active than the left is a marker for anxiety. So, when the right is more active than the left, depression. Left considerably more active than the right, anxiety. Not enough theta or too much beta back here, poor stress tolerance and anxiety. When the alpha response is poor up here, it usually means, and okay back here, usually means a current emotional stressor. When you see it in both places, that's usually historical trauma, or at least we think it is. And this is what trauma looks like. Again, just raw data. This is what it should look like. Eyes open, eyes closed. So you can see eyes closed at CZ, top of the head. Very nice response, roughly double. Back of the brain, O1, back of the brain. Eyes open, eyes closed. Nice alpha response, at least double. Okay. This is what it should not look like. This is a trauma marker. Eyes open, eyes closed. It actually went negative. Back of the brain, eyes open, eyes closed. Went negative again. Here's a major trauma marker. And the summary of it, very straightforward. Excuse me. The alpha response, negative. Went negative 15% in this case for this client. And in the back of the brain, it's basically unchanged. This is what the brainwave should look like. This is a nice, healthy brainwave. This is a work of art. And what you get is a situation in which the distribution of brain waves The algorithm is amplitude is inversely related to frequency, meaning that low frequencies have high amplitude, high frequencies have low amplitude, and it should look like this. It's a nice, healthy brainwave. And this is an alpha response. Now we're looking at exactly that same distribution here. Scale is a little different, of course. And we're going to ask the person to close their eyes, and you'll see a nice jump in alpha activity right around the alpha range, and you'll see it here in just a moment. And it will pop up. There we go. There, eyes closed, the alpha comes up nice and strong. Okay, there's a nice alpha response. Okay, and when eyes open, drops like a rock. There it is. Okay, that's what it should look like. This is what trauma looks like. Now, first of all, you can see that we don't have quite as nice a distribution here. Okay, so this doesn't look as healthy. You want to think of it in those terms. And watch what happens when the eyes are closed. The alpha will come up, but it can't stay there. It's like somebody's sitting on it. When I treat a lot of artists for this, for artistic block, this is what they all look like. Trauma has come in and suppressed their creativity wave, their alpha wave. When I describe it to them, they say, that's exactly what it feels like. It feels like somebody's sitting on my creativity. Okay, so you can get an idea here. It comes up, but it just can't stay there. So that's what trauma looks like. And here's a situation in which we have a trauma marker, and we have a depression marker, and we have poor stress tolerance in the back of the brain. So this is an individual who has trauma, depression, panic problems, sleep problems. Okay? That's the summary of it. Okay, so the summary of trauma, when the alpha response, that is the difference between eyes closed and eyes open alpha, is less than 30% on top of the head, less than 50% in the back, you know, there's your marker for trauma. There are a couple of other conditions that will also give rise to trauma patterning, in which the alpha response is slow. There are a lot of ways that we can see it, but the blunting of the alpha response is the primary marker for trauma.
Thank you, Dr. Stengel. We are now going to answer more questions. What do you recommend for a teen whose clinical neurotreatments have brought everything into balance, normal readings, including removing the trauma marker, but the family is still seeing quick anger response and high anxiety at home, disproportionate to the events?
If the frontal lobes are balanced, then we're dealing with a behavioral issue. Now, what often happens is individuals develop that are reinforced or enabled based on a genetic predisposition. So what is required are behavioral modification procedures for dealing with any kind of behavior that's being reinforced. It's a huge problem when you're dealing with teenagers. Because independence, rebellion, opposition just comes as trying to establish themselves and become more independent. When we're faced with a situation in which there's a history of extreme volatility, for example, then after you get the neurology in place, then the person no longer fighting the neurology of the situation. You need a behavioral parametering program in place to get that under control. Sometimes what we recommend is a few sessions working with a family person. And we have people in the practice who do that sort of thing, just to work out the details and help the family and the teenager come to an understanding in terms of what's tolerable and acceptable behavior. However, having said that, I would be suspicious if there's a situation in which you're not seeing some kind of reduction in that activity, that the front part of the brain is not fully balanced yet.
If F4 is greater than F3, say alpha, do you decrease alpha or use balance?
Wonderful question. Is the right more active? Is the right stronger than the left, or is the left weaker than the right? Okay. As neurotherapists, we face this all the time, and we have an idea of what it should look like in terms of absolute amplitude levels. So that sometimes tells us whether we want to increase one side or decrease the other side. Now, there are some technically, there are some things that you can do when you're uncertain. This is beyond the scope of what we usually talk about in a webinar, but if you treat both sides of the brain simultaneously using a bipolar hookup, that is where you're trying to decrease the difference between the two sides, sometimes that's the most effective way of dealing with it. You have a similar sort of thing if you're trying to treat back pain, for example. Do you strengthen the weak muscle, or do you decrease the strength of the strong muscle? And there are ways of doing that to restore balance, which of course is what the imbalance in muscle tension is what's causing the backache.
How do you train to increase alpha response?
Okay. Using straightforward neurofeedback, what you do is eyes closed, increase alpha strength. So that's the most obvious, straightforward way of doing it. So when alpha is increasing, the person hears a tone and is able to make use of that information to self-regulate alpha strength. The second is brain driving, and that's another procedure we use, and we have stimuli that will increase alpha strength, and we use it just like Pavlov used meat powder with his dogs, in which when the alpha response drops below a certain threshold, we turn on a stimulus, and it could be stimulation of an acupuncture point or lights or sound to increase that strength. When it crosses threshold, we turn it off, so we're pushing it. Third are home treatment procedures in which a person uses a harmonic to suppress alpha and then one to increase alpha, and they do eyes open, eyes closed, eyes open, eyes closed. We're actually in the process of the research and development on a product to do specifically this at home.
Okay, we should be moving on now, but I'm just going to throw in one more question just because I would love to hear the answer to this. If I'm okay and I take antidepressant, will I feel even better?
Oh, the happy pill problem. That's why we have, I don't know, a third of the females between a particular age in the United States taking antidepressants. If I'm feeling good, if I have half a bottle of vodka, will I feel better? Okay. End of question answer period.
Let's move on.
Okay, trauma release. There are a lot of adjunctive procedures we use to release, the blended alpha. Somebody asked about the neurological ways of doing it. But there are some other things. Experiential psychotherapy, hypnosis, bilateral stimulation procedures. A lot of folks are familiar with EMDR. Somato-emotional release. That's a procedure that's based on craniosacral therapy, in which there's a presumption that some of the trauma resides in body position. Probably the best example of that is if you're in an automobile accident, let's say you're the passenger, not the driver, and you see that you're going to impact another car, you might throw your hands up around, in front of your face, and then there's the impact. Now, it may be that that position of holding your hands in the position that you had just prior to the crash will evoke an emotional response. Now, we find this quite routinely, and we do some amount of emotional release on clients to release the trauma that's triggered by a body position. And here's one such example. This is a person who had long-term multiple family member sexual abuse. And what we did was some amount of emotional release in terms of allowing body position to evoke the traumatic response. And we got a dramatic change in the theta-beta ratio, for example, and in the alpha response after doing this emotional release procedure. Hypnosis is another way in which you have the individual visualize conditions, usually in a metaphor associated with trauma. Experiential psychotherapy, you take the person right back through the trauma. I'm not a big believer in that anymore. That's the way we used to deal with this. I find that neurotherapy is by far the superior way because we increase the alpha response. The trauma will come along with it. Then you go home and dream, do your own psychotherapy, end of problem. Brain driving is the other procedure that we use for trauma release. And brain driving, as I said, is Pavlov and his dogs. So these are glasses that have LED lights on the periphery. So we can turn these lights on and off based on brain activity. And a person can still see through and read, for example. Here's a setup in which we can present sound. We can present the lights that I was just talking about. These are closed so that the person has their eyes closed and we're stimulating the light. And we stimulate acupuncture points based on what the brain is doing. I got my training in Shanghai. Here's me sticking needles into people, learning how to do this stuff. Heart 6 and 7 is one of the areas that we stimulate because when it's stimulated, it increases theta amplitude. But this is in Chinese medicine what the stimulation of that point is supposed to be useful for, including nosebleeds, by the way. Here it is. There's the location. Sometimes if you just rub that area, it will increase theta amplitude in the back of the brain. Not hard. Always rub softly. And brain driving, which is the procedure we use, and here's alpha brain driving, in which we are using the heart 7. So and when the theta starts to move, we turn on heart 7. When it drops below threshold, we turn on heart 7 to push it up again. And then when it's above threshold, we turn on 10 cycles a second lights, which is an alpha frequency, to try to hold on to the increased amplitude. And you can see we get very, very nice changes in the percentages here in terms of the strength of the eyes closed alpha response between pre and post. Here you can see it doubled the percentage after, I think this was a 20-minute session. And here's trauma release. Here's what it looks like if you're actually in session. So here we're driving up the alpha, and you can see alpha comes up, triggers a trauma. So theta drops like a stone. Here's your beta amplitude. And then the individual recovers from the trauma release, and theta starts to come up again, alpha starts to come up. So it's very, very efficient. So you're using neurotherapy, and the person may stop, and you may, talk about it, do some sort of therapeutic procedure like EMDR, OEI, or whatever to help the person process it. But it's a very, very efficient system for dealing with trauma because you're monitoring the neurology and pushing the neurology coincident with that. And again, you find the trauma here and here, in which when you close your eyes, there should be nice jumps in alpha. And when there aren't, that's your marker for trauma.
Thank you, Dr. Swingle, and I'll take it from here. This is the book that has all you need to know about neurotherapy. The title is Biofeedback for the Brain. It is written by Dr. Paul Swingle and published by Rutgers University Press. It is available online at soundhealthproducts.com, or it can be ordered at Swingle Clinic. And basic neurotherapy. This is a guide for clinicians. It leads them through the procedures for evaluating patients with a wide range of disorders. It is also available online at soundhealthproducts.com. And we have few seats left for our advanced neurotherapy training in October. So for all of you professionals out there, if you would like to get training in more complex forms of brain driving and adjunctive aggressive treatment procedures that potentiate neurotherapy, you can still register. Just send me email at rita@swingleclinic.com. And we also have a lot of resources on our website at www.swingleclinic.com. For those of you who missed our previous webcast, they are all posted on our media page. And if you are not on our mailing list, you can periodically check our upcoming educational events like lectures, workshops, and webcasts on the events page at swingleclinic.com. Sound Health Products, the leader in research and development of products for biofeedback and neurotherapy, is a division of Swingle Clinic. Most of these products have been developed by Dr. Swingle through many years of his research and experience. Many people use these products, such as sound healing CDs and MP3s, as aids to enhance relaxation, sleep, and attention. We recently redesigned Sound Health Products website, and to celebrate the new launch, we offer 30% discount on any products until September the 30th. The order must be made by sending an email to me at rita@swingleclinic.com. And this is it, folks. Our next show is scheduled for October the 12th, and we will discuss neurotherapy and the family. Have a great weekend, everybody, and bye-bye.